Hey guys, welcome to the FIT Talk, hosted by three doctors of physical therapy, where we will be discussing and reviewing articles pertaining to everything physical therapy, strength and conditioning, exercise prescription, nutrition, and everything in between. My name is Dr. Michael De La Cruz, and I'm accompanied here by my two great colleagues, Dr. Tristan Bonetta and Dr. Darian Fernandez. But on today's episode, we are blessed with the guest appearance of a great colleague of ours, Dr. CJ Vaughn. He's a doctor of physical therapy and athletic trainer practicing in the state of Washington. So happy to have you here, CJ. How are we doing on this fine evening?
Doing pretty well, guys. Thanks for having me on. Just fresh off of a football practice here in my lovely kitchen, doing this discussion. I'm blessed to be able to practice in my community that I grew up in Gig Harbor, Washington, about an hour south of Seattle. And I'm excited to talk all things physical therapy with you guys. Darian, how you doing tonight?
DJ, I'm glad to have you back, almost in person. We miss you, brother. I wish I was out in the field like you are. I'm not treating yet. Sadly, New Jersey's got some stipulation I got to contend with. But once that's over with, I'll be, in the field with you guys. Tristan, how we doing?
Awesome. Doing well here in the great state of Texas. Really glad that we have the opportunity to have and host CJ here so that he can shed some light, not only on the topic, which is a very interesting topic, but again, on the differences between states and how that is affecting each of us differently.
Absolutely. And I think this is going to make for a very interesting discussion. So, on the previous episode, we discussed the neurophysiological effect of a single session of joint mobilizations. We're going to layer that on today. And today, what we're going to talk about is a hot topic, highly debated topic. We're talking about manipulations. And we're going to dive into it, talking about the safety of thrust joint manipulations within the thoracic spine. And you'll see today how we really need to question what's going on. And CJ will shed some light on how the states vary with the ability to carry out practice manipulations. So with that being said, Tristan, let's dive into it.
Yeah, so let's dive right into it. We're talking about a title of Safety of Thrust Joint Manipulation in the Thoracic Spine, a systematic review. The authors of this article are Emilio Puentedora and William O'Grady, previously from the University of Nevada in Las Vegas and the Department of Physical Therapy in Las Vegas, Nevada, USA. So these fine gentlemen have been working very hard and judiciously around manipulative therapy, manual therapy, and physical therapy all alike since a very early time. This is an article from 2011. So if you start with the article, 2015, excuse me, sorry, 2011 was a different article from Emilio. He has a lot of stuff, but 2015. So of recency. But if you start with the introduction, he talks about a lot of the differences between interchangeably the words that we use in physical therapy between joint mobilization and manipulation. He says a significant problem with research into spinal manipulation is that precise definition is often lacking. The terms of joint manipulation and mobilization are often used interchangeably. So he says, and he defines a thrust joint manipulation to the spine differs significantly from a non-thrust joint mobilization is that the rate of vertebral joint motion, so the speed of the technique, does not allow the patient to prevent its occurrence. The thrust joint manipulation techniques involve application of high velocity, low amplitude forces. So for this article, they are going to be discussing and focusing on adverse events associated with application of thrust joint manipulations. For the purpose of the article, they define adverse events as medium to long-term duration, moderate severe symptoms, and of nature that is serious, distressing, and unacceptable to the patient that requires further treatment. So they talk a little bit about the definition of the technique they're using, as well as the definition that the authors use of adverse events mentioned. Do you guys have anything else in the introduction that you thought were particularly of importance? Mike, we're going to start with you. Anything in the introduction, page 1, 2, or 3 that you thought was important?
It's not so much that I find it important, but I think it makes for good discussion because we see that we're taught in academia because there's a baseline that has to be taught of thoracic and lumbar manipulation, and they just teach it. And from there, it's like, okay, you have these new clinicians, these students that are just doing thrust manipulations, but at the same time, I'm going to throw a little, I guess, curveball in here. Cervical manipulations aren't taught, and we demonize the neck a lot, but we also teach thoracic manipulations all the time. And you have these students just wailing on each other. How safe is it? And I think that's the question we have to ask, and that's something that we're going to dive into here. And I'm hoping that for our listeners out there, this starts to create some sort of thought-provoking questions that may come up in your mind, and start asking those questions and challenge the status quo of, hey, let's teach a thoracic manipulation, call it a day.
Yeah, no, I definitely understand where you're coming from. I mean, Puentador himself mentioned an article that he worked on that reported a higher incidence of side effects with patients receiving these thrust joint manipulations to the thoracic spine compared to even the cervical spine. I want to also add the forces. There's different forces that are applied to the thoracic spine, to the lumbar spine, and to the cervical spine, respectively. Darian, did you have any thoughts on the difference of forces that were applied, as well as the in vitro failure to load forces that were reported by studies to the thoracic spine, respectively? Do you have any thoughts on that? Is that an area that concerns you when performing thrust joint manipulations?
I think when you just look at the numbers, right, I don't think it's too hard to discern that it's not hard to push too hard, right? And we don't need to dive into the math and look at all the ratios per se, but on average, if you do a bunch of thrust in vitro, your average thrust force is going to be around to a little bit above what the body supposedly can tolerate. Now we don't know just how perfectly in vitro to in vivo statistics translate, but the point is pretty strong, right? We can thrust too hard, and it's not that hard to do so. So I think that's an important disclaimer for us to be mindful of, because like what Mike was saying, right? It's pretty commonplace. We learn how to do T-spine, right? Maybe lumbar spine. But that is actually what this is saying, more dangerous and easier to hurt somebody than C-spine, which we don't learn. So I think that was well said there.
And I think, Darian, to your point there too, we see so much literature on the safety of cervical manipulations, and it seems to be so fear-mongered in our profession and in the healthcare professions. And I think it's nice that we're discussing this, because we need to bring to light that not only do we need to respect the C-spine and do our screens, make sure that we do our due diligence, but we also need to do that with the thoracic spine too. And I think sometimes that gets overlooked, and we're not as conscious of it because we're not thinking, oh, it's the neck, it's the neck. I think it's very important that we do our due diligence as well, not only just in thoracic spine and lumbar spine, or any manipulation that you're doing. So I'm happy that we're going to discuss this, and I think it's a very important topic right now.
You know what? And that's a good point, CJ, that you mentioned. You talked about screening appropriately and understanding, using essentially clinical decision-making to kind of help navigate your interventions, right? And I want to look at page 2, kind of the ending of the paragraphs, right next to the tables 1 and 2, where Puentadora and colleagues say thrust joint manipulation should never be performed when contraindications or precautions are present, suggesting that risk for an adverse event is just unacceptably high for this patient. Table 2 has relative precautions, right? Which would be something that Puentadora would suggest don't manipulate. This is anything from disc herniation to growing children to physiological dependence on a manipulation. When you see something like a precaution, like a growing child or a disc herniation or protrusion, do you agree with that statement that Puentadora said on these are absolutes? You should never manipulate these patients, Mike?
Well, so I'm glad that we're going over this and we're talking about it, because I think this is one of the main things that comes up in discussion when we start talking into being evidence-based practitioners. We read so many articles, and we dive into the literature, but what I think needs to happen too is we need to realize that research is here to, yes, prove if something works or it doesn't work, disprove whatnot, but it's also here to help guide our clinical reasoning. Research was never designed to be able to read and just take away your clinical reasoning and be like, this paper says this, so we got to follow this. It's meant for us to read it, digest it, formulate our own opinion, and help guide our treatment. So for me personally, while there are relative precautions, contraindications, all that, and then there's your absolute contraindications, I think when you're reading these type of things and you see these things, it's something to keep in your mind that you need to process and say, hey, do the benefits outweigh the risks? Can I carry out this technique appropriately? Or am I not skilled if maybe I should hold off and should I maybe try a joint mobilization or something less quote unquote aggressive and see how they tolerate it first, and then can we progress to that, right? And I think that's where a lot of it's lacking. I was talking to my student I was mentoring today, right? Everybody just jumps right to it. Well, what if they're not ready for it? Can we mobilize? Can we introduce it and then work up to that? Because we see these relative precautions and contraindications, but again, the key word there, relative, right? Where's our clinical mindset at?
Yeah, I think to that point as well, talking about skill set, it's not a knock on new clinicians or clinicians that don't practice manipulation often, but I think the greatest sign of expertise is knowing your limitations and understanding, if I'm comfortable performing this with somebody, and that goes right along with our clinical reasoning that we just spoke about.
Mike, I actually had a question for you about this. Regarding one of the absolute contraindications. Now, I know we're talking about the T-spine here, but it mentions acute soft tissue injury. And forgive me if I'm wrong, but I think you were talking about something you read regarding ankle sprains and manipulating ankles in acute sprains, right? Any thoughts? Can you elaborate on that? How that might relate to the T-spine?
Well, so if we take that idea, I believe we're talking about Julie Whitman CPR for acute ankle sprains benefiting from thrust joint manipulation to the ankle. The theory there is when you have an acute injury, the local tissues and structures shut down because they're trying to protect everything that's trying to heal. But when that happens, right, we lose all joint proprioception and whatnot, mechanoreceptor activity goes haywire. And with that thrust, if we can grade it properly, we're able to give some input to the system, get the muscles to start firing again, jumpstart a rehab process. And if you take that thought process and you apply it to the thoracic spine, I think you'll get similar results. And they've actually done it with a study with Josh Cleland, where they looked at manipulation to the thoracic spine and it was able to facilitate the lower trap. So if you have a soft tissue injury and it's acute, can you manipulate it? Maybe. Use your clinical reasoning, your clinical decision making, right? Can the patient tolerate it? Can you grade your forces appropriately, right? We see the thoracic spine and we see all the ligamentous structures and all the bony structures, the ribs, and all that. We think that it's this big, robust structure. It is, yes, but it should still be treated with respect when we're carrying out these techniques. So I'm not sure if that answered your question.
No, I think that was a perfect response. So the reason why I brought it up, right? If we think about what soft tissue injuries might you see in the thoracic spine, right? There's ligament there, there's muscles there. Those are probably your big two that you're looking at, right? Let's say you have a muscle strain. Okay. Your manipulation position isn't putting the majority of your T-spine muscles in a position of danger, right? So if you're doing your technique correctly, not being rough with your hands, low amplitude, right? You shouldn't hurt that individual anymore. So I think that was really well said. I think, maybe don't take it and run if you're a new clinician and go manip people who have acute, mid back strains. But it is notable to say that you can mobilize them probably, and if you are good enough, you probably can manipulate them, right? Because research is not the be all end all.
Correct. And before we move on to methods, I do want to add an excerpt from a skillful clinician that has mentored us in many different ways, both individually and both collectively as a group. His thought process on this, and I'm not going to disclose the name, but his thought process on this is risks versus reward. He says an article are guidelines. It's written for the masses, for the average mean of a clinician. That does not mean that there aren't times when a skilled clinician could take into account the risks and skillfully deliver safe treatment. So again, it's always about you as a clinician feeling confident and comfortable carrying out that technique and using sound clinical judgment as advised. Furthermore, we're going to head over to the methods. Although they really tried to get an extensive search, the authors were unable to find any published systematic reviews of adverse events following thoracic joint manipulations to the thoracic spine. So they ended up having to settle for case reports published in peer-reviewed journals. They have a pretty detailed search article where they are able to find and allocate the meaningful cases, which resulted in a total of 10 cases reported in 7 different articles that were analyzed for systematic review. Anything for the method section that you guys want to go over? Anything that you thought was important to bring up?
Well, I think in this scenario, I actually like that they had to default to the case reports. I think all too many times we disregard case reports because they tend to be lower on the hierarchy of research and evidence-based reports. Me personally, I used to think like that as well because we all think in that manner, especially coming out of school, because we harp on the meta-analysis and systematic reviews. But you get a lot of information about these case reports, and especially when we're talking about a topic like this that's highly controversial, whether we should be doing it or not. These case reports shed a lot of light on what's happening with patient presentations, especially when we apply these things.
Yeah, I agree. I
Yeah.
think there's a lot of value in case reports. CJ, do you have anything about how they looked at the wording of what they were searching for when they tried to find systematic reviews?
In a lot of the articles we read, immunotherapy articles, I'm sure you guys can attest to this. They throw around mobilization and manipulation a lot as one and the same. And I think if we're working in the realm of skilled physical therapy, I don't think that that's true. I think they're completely different. As far as the intent with a manipulation versus a mobilization. Now that could have limited, the research they actually found, because if they didn't use the search term mobilization, they use manipulation. So there could have been some articles that had been missed out on because of that. But back to Mike's point as well, I do like that they have case reports because I think, the pyramid of evidence and what is quality, what is not, and throwing expert opinion at the bottom, I think is something that shouldn't be as black and white as it is. I don't think expert opinion should be at the bottom, and case reports highlight expert opinion, and they show that I worked with this patient, we saw this, and this is what happened. And I think that's so important because everybody we work with, we're building our own case reports in our head that help with our clinical reasoning and our clinical expertise. So while I think there may be more out there if they use some different search terms, I do think that these case reports are valuable to the level of evidence that this brings and to light of the safety of this manipulation.
Yeah, Darian, any comments before we move on?
Sort of, not to nitpick per se, but I don't know if I totally agree with what you said about is the intent of a mobilization or manipulation totally different. I think it's a semantic thing, but there's definitely overlap in what they're meant to be used for. But I think for the intents and purpose of this article, I think your point is valid. It's not the same in this context because the risk of injury or harm is obviously not the same.
Right.
Yeah.
And to build on top of that, I'm sorry, Tristan, I'll hand it back to you in a second. And that's the thing here, the distinction, the dichotomy between mobilization and manipulation, right? There's a lot of overlap, but we know that there's a lot of overlap. Other clinicians might not know that, where they think, hey, manipulation is only for range of motion and malposition. Well, it's not only for that, but we know mobilization for grade 1 and 2 is for pain modulation, 3 and 4 is for range of motion, increasing elastic properties of the tissue. Manipulation does the same thing, right? We're dating back to the previous episode. It taps into the cortical regions, neuroplasticity, pain modulation, all that good stuff that manual therapy does in general, right? It's a broad spectrum. But for us, we know that, and other clinicians, I don't think there's a good population within our field of physical therapists that don't understand that manipulations and mobilizations overlap like that. There's a lot of dichotomy going on.
Yeah, no, I definitely think that those are definitely valid points that needed to be highlighted. And as we move towards the results on page 3, they highlight a section called demographics. They want to give us just a better understanding of the 10 cases that they reviewed. And they had these 10 cases that involve 2 males and 8 females. I'm a big demographics guy. You know, every time there's an article, I look at those demographics and I really try to understand who exactly are we assessing, because we're assessing an article, but we're assessing the population that they use, whether it be a randomized control article, a systematic review with abundance of articles, or even case reports. I want to know, what type of people are we looking at? They have two males with an adverse event and 8 females. Does anyone have any thoughts on that? Just looking at male to female and why adverse events might be different in these small 10 cases, why it would look like a 20% to 80% type of difference. Anyone have any thoughts on that?
I got plenty, to be honest. I love demographics too. I think you have a lot to learn from who we're studying, right? Yes, it's case studies, but we're studying people here, right? That's a 4 to 1 ratio, 80 to 80, 20. Yeah. That's significant. Yes, our numbers are very low, so that statistical power is almost nothing, right? But I don't care. You can blow that, you can magnify that data pool 100 times, and I bet you that ratio won't change that much, right? 5 to 1 significant. Why is that, right? Well, if you look at the risk factors, metabolic is a big one, right? And what does that mean? That means osteoporosis and other similar disorders, conditions. Maybe might be a better way to put that. I don't think it's an accident that most of them were female. Anyone else want to add before I take that deeper?
Yeah. Go ahead, Tristan.
I think when we are looking at the type of forces that we're putting in the T-spine, I think as clinicians, there's so much going on with the manipulation. They have a hard time grading forces. I just think it's that simple. I think it's like we are wailing on people sometimes. And I think that's something that definitely needs to be changed. And people think like, oh, C-spine and lumbar spine, those are the areas I need to be cautious. And I really think it's that ratio because we are just so nonchalant with the thoracic thrust joint manipulation.
And I agree. And the ratio to me in my mind strikes like that because again, we learn these techniques in school, but how much time do we actually spend refining and practicing these techniques and trying to appropriately grade forces, right? Like how many times are we doing like a round robin session where we're switching partners and changing it up? You usually stick with one partner throughout school and you get used to their body, but everybody's body is different, especially when you start throwing metabolic disorders in the mix of things, right? Because like in the last episode we talked about it, right? Manual therapy has non-specific effects, but that doesn't mean we sacrifice our technique and our ability to withhold the standard of care, right? And especially with these techniques that are termed or deemed more aggressive, you know, can we practice it to the point where we can safely carry it out in the presence of these different disorders? And there's one thing that I want to add in here, and that we talked about in the introduction. Doran mentioned there's a 30-pound force discrepancy between the thoracic and the lumbar spine. It's a large amount of poundage that's being changed that we don't even know is going on. So imagine when you have these clinicians that just say, I think they need a thoracic manipulation. I'm not really sure. Let's go for it, right? And then they just wail on them. And I think that's part of the reason why you have such a discrepancy, right?
Yeah, and then furthermore in that results section, they talk about adverse events, right? And what exactly they found in the results. Adverse events were reported to the spinal cord 7 out of the 10 cases. There was cerebral spinal fluid leak. There was dural sleeve injuries. There was symptoms that were progressive weakness, paresthesia in the lower extremities, thoracic pain, nausea, single incidences of shortness of breath, at rest, neck stiffness, photophobia, severe headaches. So these adverse events weren't just your common joint soreness. And I think all of us have gotten some sense of joint soreness as reported by the patient. And that's something that I think we all now tell them is expected. But these were not that. These were pretty serious adverse events. And before we go to the discussion, I think if you take a look at table 3, that kind of speaks more about the results and the demographics. You see 1 through 7 having an issue with the spinal cord, either cord compression, epidural tumor, fractures, swollen cord, things like that. And the ages of these people: 64-year-old female, 60-year-old female, 56-year-old female, 71-year-old female. And then we have the outliers: the 32-year-old male, the 45-year-old female, the 38-year-old female. The one thing that I do want to question is number 9. In 2007, a 20-year-old female reported a right pneumothorax with symptom onset that lasted 24 hours. So that was something pretty serious too. So we see it from all over the place: 17-year-old males, 20-year-old females, to even 71-year-old females. So again, I think that really highlights what you were kind of talking about, Mike, and what we've been discussing. We really need to grade our forces. Anything else in the results section that we want to harp on or emphasize before we head over to the discussion?
Yeah, I think it's if you want to go in the stats a little more, right? So like you had 10 people we looked at that got seriously injured, right? Beyond recovery. 7 out of 10, 70% had a spinal cord injury, right? Okay. 3 out of those 7 had a T4 issue, right? So if you want to look at what area of the spine most susceptible, I mean, I'll say it again, this is a very small data set, but our ratios are still significant. It's not 1 out of 10, it's 3 out of 10, right? You can blow that up and it still might not be that different. T4, T5 seem to be the most commonly injured area. Any thoughts on why that might be, guys?
I'm thinking because clinicians have a hard time. I see this anecdotally when they're doing the T-spine, getting really over and putting their body weight on a specific point at any spinal segment. And I think at T4, the given way that most schools are approaching thoracic spine manipulations, that's just an area where you tend to find the most overlap of people actually putting their body weight on a single specific area of spinal segment. So I would think combine that with an inability to grade your force, and that's probably that most susceptible area, just given anatomical location. That's what comes to mind.
And I think too, it talks a lot about T4, but also it kind of majority of them are anywhere from T4 to T7. And I think it's just probably the most common place area we're manipulating, right in between the shoulder blades there. That's where, we have our kyphotic patients, or our, a lot of complaints from patients too happen to be right in that area. So I believe maybe that is a reason too, is that's the most common area that we're manipulating. Again, as Darian says, it's a small data set, but every time we practiced, in school and the majority of patients that I've done this on, I'm usually right around in that area. And that's kind of where I get the most bang for my buck is in that area. So I think that may allude to a little bit of that as well.
Yeah. I think that's kind of what I was getting. I don't think it was, super deep or anatomical in essence, but I think that's where people hurt a lot and where we press on. So I think it's not shocking. Yeah. I think if we had a very large study of 1,000 adverse events, I still think we'd see most of them happening in that center T-spine area.
So as we transition to the discussion, we want to add that the authors state the discussion by saying there was a surprisingly small number of case reports involving serious adverse events. And rather than inferring that serious adverse events following thrust joint manipulation to the thoracic spine are extremely rare, it's more likely that such events are underreported, right? The most frequent reported adverse event following a thrust joint manipulation to the thoracic spine involved acute trauma to the spinal cord, given cases 1 through 7 in table 3. And it's presumed that the technique may have been given with such force that either bruised the cord, fractured a vertebrae, herniated a disc that led to further damage of that cord. With that being said, the discussion section also takes into account other literature that has used such ways to mitigate these adverse events from occurring. Minkin and colleagues used 6 categories that suggested an proposal to include the rate of force application for more standard information regarding manipulation. So you're thinking rate of force application, location and range of available movement, direction of force, target of force, relative structural movement, and patient position. So additionally, cases should include the total numbers of techniques that are used, for what the condition was for, the clinicians that were performing these techniques, and the description of the examination procedures. This is all to help us in further literature rule out contraindications and precautions and give us just more clinical insight on how to prevent adverse events when applying thrust joint manipulation. So those are ways that we have seen in the literature over the past couple randomized controlled trials, and hopefully we see a lot more of that, because it's really going to allow us to take the information that is being researched and apply it to everyday practice. Do you guys have anything specifically to talk about in the discussions that y'all thought were specific or important to our discussion of late?
I think when I spoke earlier about the difference between manipulation and mobilization, and I said intent, I think this is more of what I meant, more intent with our hands and what we're doing, not necessarily, you know, the neurophysiologic effect that follows. And we could have a whole nother episode talking about, you know, should we chase the cavitation? Should we not? Are we going to get a grander effect? Are we not? You know, referencing the Bialowski article from 2018. But I believe, you know, rate of force application, location of our hands is so important. And it's why we really need to, in the literature, differentiate between the two, manipulation and mobilization, to further supplement you know, what we mean by skilled physical therapy as far as manual therapy and manipulation.
I think CJ is just hitting that nail right on the head, and you see it here in the discussion. You know, Poinador noted, it's likely that these adverse events are being underreported because, again, some of these things take time to manifest. And it's either that the patient went back to the practitioner, said something, and they try to, you know, remedy the situation, or the patient said, "This guy doesn't know what he's doing. I'm not going back. It hurts," right? So it's underreported. But then also, if you look on, where is it? Page 5 at the right hand side at the bottom, there are reports of maximum peak force loads exceeding 125 pounds of force to the thoracic spine, right? This is where we need to be skilled with our hands and realize that, hey, just because there's a lot of bony attachments here and it's a very, again, robust structure, we cannot just be wailing on this thing, right? That's not how what a manipulation is. Manipulation, by definition, grade 5 mobilization, yes, but it's high velocity, low amplitude thrust. If we're adhering to that definition, there's no reason why we should be applying 125 pounds of pressure through someone's back. And I think CJ is just hitting this thing on the head in terms of being skillful and using our hands with intent.
And for the listeners out there too, do you guys have any good references, you know, in regards to any manipulation, especially the spine, that refer to how much force is necessary to get the desired effect? You know, have you guys seen anything in the literature from any specific authors that are reporting, you know, what do we need to essentially make it a manipulation? You know, how much force for, you know, cervical, thoracic, lumbar, anything?
Yeah, that's absolutely correct, right? We don't know how much. What really defines it as being a successful manipulation? For our listeners, challenge you, and if you guys have anything, let us know.
Yeah, anecdotally, at least, it's always as much needed with not too much. And that's always like the thing, like just do enough, but not enough needed. And that's when I think that kind of disconnect between just, we need more reps in school, we need more round robins in school, and we need to build confidence earlier in younger clinicians when applying these techniques, so that they understand that the high velocity, low amplitude thrust is never going to be a number that is X, Y, or Z. It's always going to be dependent on that individual in front of you, right? So it's really hard to say you need a certain amount of pounds or force to get that desired effect, when the desired effect or the application of the technique when compared to a individual that's 6 foot, 250 pounds is going to be vastly different if that individual is 5'4", 120 pounds, right? And I think we first have to just instill confidence and instill refinement with our younger and younger clinicians. And I think that needs to start at a young age. Darian, I have a question for you, though. In the discussion section on page 6, it says that in a review, they discuss some of the transient side effects in their literature review, and how it's reported that 60% of the time there's a transient side effect reported in the thoracic spine following thrust joint manipulations. Why or what kind of goes to your mind when you think about 60% of the time there's a possible adverse event? Do you think we're emphasizing adverse events that are just normal occurrences, like joint soreness or things like that? Or do you think there's an underlying issue that may be at the forefront?
So first, thank you for that question. And I think I'll start answering it by piggybacking off of what Mike was saying about the underreporting. I think it's important to clarify that the underreporting that this article is referencing has to do with the transient side effects, the less severe ones, because you don't really talk about it if your back hurts a week after therapy when it hurt before that too, right? So I think, I guess, to attribute to the power of the article, even though there's a low number of articles they found, that's also significant. It was hard to find cases of this, right? To your point about what does that mean? Like, what are these transient effects significant, I guess, meaning to me as a clinician, right? These transient effects, to be honest, right, are very ubiquitous. These are effects you can see with immobilization. You can trigger point somebody to it. You can do some grafting too hard. A lot of these effects are not just unique to manipulation. So I think it's important to understand that context, right? We're honing in on, oh, you can get manipulated, your back might be sore. Well, same mobilization. And why might that be, right? Why might we have ubiquitous effects that are the same through multiple techniques? Well, because when you're manipulating somebody, if you do it right, it's quick, right? You're not there, you should be in and out, right? So yes, there's more force, but how long is your body taking that force? Maybe a half a second during the actual thrust, right? You're mobilizing. Okay, you're there for a couple minutes. Maybe you don't ever get to that peak force, that grade 5, but their body was sustaining a force for a long time. So I guess the follow-up point that I want to ask these authors, they didn't talk about, is what's the incidence of transient effects from mobilization as we understand it? Is that more or less the same as manipulation? And that's what I offer you there.
Yeah, no, those are definitely good questions to ask. And I think that's why in the limitation/discussion section, they kind of talked about the categories that were suggested by Minkins that would kind of give us more understanding of exactly future research and how that's going to aid us in clinical decision making. We're going to also discuss a little bit about how these laws and litigations around thrust joint manipulations has affected some of us differently. CJ, we really brought you on not only for your intelligence around the orthopedics and sports orthopedics realm, but also because you're at a unique point where your state has possibly affected your practicing clinician kind of way of your treatments. And we want you to highlight sort of what exactly your state allows you to do, why it may not allow you to do certain things, and how it affected your practice.
Well, really just to start, in Washington, physical therapists have to obtain an endorsement from the state in order to manipulate the spine. And there is a laundry list of boxes that we have to check in order to provide this treatment, which I think, in my opinion, is my job and something that everybody should utilize to an extent. I always like to say manual therapy is only 10 to 15% of what we should be doing. Right. So I'm not saying that this is a cornerstone. Everyone has to get an endorsement and to do this, but I think it really affects my practice because it is something that, I find really effective with a lot of my patients. And just to quickly run down the laundry list of things I have to accomplish. I have to practice first and foremost for a full year before I can even apply for this endorsement. I have to have training in differential diagnosis of no less than 100 hours outlined within a course curriculum, to have didactic and practical training related to the delivery of spinal manipulative procedures of no less than 250 hours, clearly delineated and outlined in a course curriculum. I have to have specific training in spinal diagnostic imaging of no less than 150 hours outlined in a course curriculum, and at least 300 hours of clinical practice experience in spinal manipulative procedures. I basically have to go back to school in order to get this. And it seems very excessive. And, there's a lot of blog posts and different things that allude to why this is even in play. And to take it back to 1980, we gave up spinal manipulation as a profession in the state just to obtain direct access, just so we could have patients come directly to us. So right there, we gave it up, right? The profession at the time saw it as a win. We don't need to do this. We just need to get patients in, and we want to see them without having to get a doctor's referral or prescription, right? As time went on, PTWA, which is PTWA in Washington, they kind of pushed back and they say, this is part of our practice. This is what we should be able to do. And they passed this bill, which was, I believe, in 2013, that required the laundry list that I spoke about. And there's some language that of why they accepted this bill. And I found it very interesting. They said, we accepted this highly restrictive bill language because Washington State Chiropractic Association promised to be neutral and not oppose our bill. Legislators, tired and weary of the scope of practice issue, saw a deal was close and wouldn't accept further amendments. If PTWA withdrew support of this substitute bill, the likelihood of reintroducing another bill anytime in the next 10 years was nil. So it was almost like, hey, if we don't do this now, it's never going to happen for us. And now we're in this predicament of, all right, I have to be very careful of the language I use in the clinic. I can't just throw out the term manipulation. I can't advertise that I perform manipulations. I can't even advertise it if I own my own practice. I can't say, hey, this is what we do here. We do manual therapy, we manipulate. I can't even say that. And I think it's something that is definitely limiting in my practice. I've spoken with physical therapists that say it's a lot easier than it seems to get the spinal endorsement. And I still have more to learn about why that is and how to jump through these hoops. But it's a very hot topic, and it's not only seen in Washington. There's some language in Florida. There's some language in Indiana and Tennessee that also kind of limit physical therapists' ability to perform these techniques, specifically on the spine. So it's I'm happy that you guys brought me in to talk about this. I'm pretty fired up about it, and I'm ready to get this endorsement so I can start doing my job. And I took a lot of courses with you guys too, and I'm prepared to do these things, and I have to kind of dance around my language and things like that. So that's kind of just a quick breakdown right there of the law itself.
I think you good.
When you see laws like this affecting you at home, literally at home, you went and you got schooling somewhere else, you came back home to serve your community, the best of your abilities, right? When you see laws like this that literally affect you at home and the way that you practice, does it feel like a slap in the face? Does it feel like, I'm claiming and I'm going and paying to be a doctor of physical therapy, to be an expert in the muscular skeletal realm, and to see language like this, or to see a divide of what you can and cannot do, does it at times feel distasteful? Like, how do you, as a young clinician, how does it feel just them saying, hey, you need to do XYZ still?
Yeah, it can feel like that definitely at times. And I, pursued this profession to become an autonomous practitioner. And I feel like some of that autonomy is almost kind of taken away from me. I can have a chiropractor oversee me doing these techniques when a lot of the chiropractors I work with don't even manipulate on a regular basis. And I think that's a huge discrepancy too. And, it it's frustrating to be limited in my practice. And when I identify a patient that is a quality candidate for a technique that I'm confident in performing and that I think I can really make a difference, and to be limited in that it's definitely frustrating. And I hope that in the future and going forward, this language will change and we can make a difference and try to help other professions to understand that this is something that we can do. And it starts at the educational level too, like you said earlier, Tristan, I believe you alluded to. We need to more practice, more round robin. We need to emphasize this in some of our curriculums. And you see a lot of these PT schools that aren't focused so much on manual therapy and more focused on, okay, let's pass the boards, right? Whereas we were blessed enough to go to a school where they really emphasize manual therapy, and to come from an arena of, manual therapy, then manual therapy movement. That's kind of the cornerstone of my treatment, is let's follow up my manual therapy with exercise. And then coming over here and being limited in that it's definitely frustrating, and something that I'm going to try to pursue and get this endorsement as soon as I can.
I think you are doing an exceptional job, and I want to thank you and applaud you for coming on here and putting all that out there, because I think these are things that people need to hear. There's so much discrepancy within our practice that varies across states, right? And you said it yourself, it's affecting how you practice. You came to another state, you went to a school that emphasized manual therapy, and we were very lucky that we had that. And you essentially adapted that to do that, and now you have to go back and to your home state of Washington, where now you're so restricted in what you can and cannot do. We see another colleague of ours, she's having the same issue in Florida, where you can not manipulate, where she had to study to actually sit down, study, go to a prometric test center for her jurisdiction, and to be tested on it, to know that, hey, and even said it too, that, hey, we cannot perform manipulations. And it even said it's not within our scope of practice. To say that is just mind-boggling, and it's astonishing to me, right? Because these are things that we learn, techniques that we can do, that we should be able to carry out. And I think this is part of where we need to come together and fight the good fight together. CJ, you're doing a great job. You're fighting that good fight already. You just got back to it, and you're on it. I applaud you. I love that. But us as a whole need to come together and fight the good fight, and stop targeting each other, but really, try to advance the profession. We harp too much on each other. We're never going to push the profession forward by doing that. But if we can collectively, attack this issue of what we can and cannot do, we're doctors. We went to schooling for this. We did the work. We did the didactic work, clinical work, all that stuff. We pushed all that out. We have our degrees. Let's start using it and push the profession forward, right? Once we are able to do that, then we'll really, truly be able to make an impact and not be so limited, right? And truly practice as autonomous practitioners.
Yeah, I think too, even when we get the endorsement in Washington, it's still a little frustrating, some of the language around it, as I'm reading through the law specifically. Even after I obtained this endorsement, some of the wording is a physical therapist holding a spinal manipulation endorsement under subsection 1 of this section shall consult with a healthcare practitioner other than a physical therapist authorized to perform spinal manipulation if spinal manipulative procedures are required beyond 6 treatments. And it goes further in saying that if you're holding the spinal manipulation endorsement, we may not have a practice that constitutes that as the majority of our services. We cannot practice or utilize chiropractic manipulative therapy in any form or delegate spinal manipulation, and we can't even bill for it. So it's even though, yeah, I get this endorsement, I feel so limited. And, talking about beyond 6 treatments, I think it speaks again to clinical reasoning. And I'm a firm believer in manual therapy. If I'm doing the same technique for max of 3 to 4 sessions, it's either not the right technique or it's not the right patient for that technique. And I think, again, speaking about autonomous practitioner, we have the skill and the training to make that decision. And the laws are almost essentially saying, you're going to do this for 6 treatments and then you got to consult somebody else. Like, we don't know that, hey, if that didn't work 3 times in a row, why am I going to continue to do the same thing? So this language is definitely frustrating and something that I hope can change going forward.
CJ, I had a question for you, because I know you're diving into these laws and how they vary across states. To your knowledge, because I know you have to do this mentoring and pretty much, I guess, coursework to be able to perform spinal manipulations. To your knowledge, are you restricted in Washington from not only performing spinal manipulation but also peripheral extremity manipulations as well?
No. So I can, right out of the gate, I can do peripheral manipulations. So there's no language or limitation at all about that.
There's the discrepancy right then and there. We can manipulate someone's joint potentially to throw the baby out of the bathwater, break someone's arm, but I can't do a quick thrust to someone's vertebral column.
I'm sorry, CJ. I'm just listening, taking it all in, man. I'm just feeling more and more bad for you the more I hear this. Especially because we know you, man. We know you came from like the mecca of what we think of physical therapy is, and now you're thrown into like this purgatory essentially where you're hamstrung. I think it's crazy because we're a doctorate profession now. Granted, it's an infancy, right? We're just newly doctorate profession, regardless, we're still doctors. We're the only profession with that title who is told by other doctors or even non-doctors what we can and can't do. That's wild. And I think it's crazy because, or even like, why is that happening, right? Because PT is so powerful, and not from a corny PT sense. It is so powerful because our box is so big. And everybody else is trying to shrink our box. And that's the problem, right? I think Washington got kind of hamstrung, for lack of a better word, right, into shrinking its own box so it wouldn't shrink any further, right? Like, we're shrinking ourselves, but don't make it any smaller, please, right? And that's where you guys are stuck at. And I think, Washington's lucky they got you, man. You're gonna push that forward, and I think you're in a sticky situation because, on one sense, I want to say leave, dude, come back, like, or go somewhere else. Why should you have to fight that fight and have your ceiling cap so low from a manual therapy perspective? But then again, how are we ever going to push PT forward from a national perspective if guys like you leave and give up and watch? Right. So I think you stay, man. We're lucky to have you.
And to your point too, I think it also falls on us as well. And I don't say this for clout reasons or trying to boast about the fact that we're doctors, but a lot of times the words physical therapy aren't associated with doctor. A lot of times it's, oh yeah, call me by my first name, blah, 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 which is fine. And I love that. I want that therapeutic alliance with my patients. Call me by my first name. Yes. But from a professional standpoint, from a standpoint of, hey, I am a doctor, I am an autonomous practitioner, I think we could do ourselves a little more favor by saying, emphasizing more that we went through this education. We are autonomous practitioners, and yes, my name is Dr. Vaughn, my name is Dr. Barrera. Like, I think that's important too, if we speak about language and just helping laypersons and getting more recognition from other professions is that we are doctors, you know, and I think that's a really important point. And even, you know, before I went to PT school, you know, when I was in physical therapy, I had no idea that this person was a doctor. Like, I didn't know they had a doctorate. You know, I had no idea. And, you know, I think we could do ourselves some favors there. And it's not for clout or boasting. I think it's just it's important.
Recording stop.
No, I definitely think, CJ, you hit some very good points there. And as we kind of circle back to the article that we're discussing, as we look about some of the conclusion points that the authors talked about, I think one of the important ones is that the review showed us that serious adverse events do occur in the thoracic spine. I think what we had as far as the disconnect between spinal manipulations in the cervical and the lumbar and thoracic is just not very transparent from school to the clinic. And I think being aware of adverse events occurring in the thoracic spine is important to know. It's suggestive that peak forces to the thoracic spine can be harmful, and that articles like this need to serve as a cautionary tale for clinicians to work on not only their refinement around the technique, but also their grading of forces around this technique. I think when we talk about this article, though, and the safety of thrust joint manipulations in the thoracic spine, I think they are safe. I think if we're doing our due diligence and using sound clinical decision making, they are. And that's my point of view, and that's my stance on thoracic joint manipulations in the thoracic spine. What about you, Darian? What do you think?
Well, I think I'll use guns as an analogy, man. I mean, you're in Texas, you all have guns, right? Are guns safe? Well, who's using it? Right. I think a gun can be very safe if it's used appropriately, but if not, it's very harmful. I think T-spine manipulation is very much the same way, right? Who's wielding it and how are you wielding it? If you do your due diligence, if you do a proper and thorough subjective and objective screening, and then you go and do the technique correctly, of course it's safe. We know that. But then if you're overconfident, if you don't have that skill set, right? Or if you didn't do your screening, no, it's not safe. I think that's very, very clear. But I think the research, at least this study, at least shows overwhelmingly that PTs do it safely. You know, there was like over 400 studies they found their search terms. 10 of them were valid. 9 weren't PTs. 1 was a PT. 1 was a lay person. So I think, you know, that in itself is pretty significant about safety.
Yeah. And what about you, CJ? What would you conclude from this article?
You know, I think just based off of this, I definitely agree with Darian's point. But I will say this too. You know, I think it's you know, the fact that only 1 PT was in this study that found to have adverse events. I think we're also just not physical therapists aren't utilizing these techniques. And it goes back to, I believe, Punta Dora had another article, I want to say it's 2016, that spoke about why are we not utilizing these mobilizations and these manipulations. And it wasn't from lack of skill. That wasn't the main factor. It wasn't even a lack of being taught, you know, these manipulations. It was because the clinical instructors that we follow just aren't using these techniques. And I think that's so important, and why, you know, you sign up to be a doctor, an autonomous practitioner, you sign up to be a lifelong learner. And I think that's something that we sometimes miss, and something that will really help us continue to push this forward. And coming from the school that we went to and the experience that I have, you know, I think these techniques are safe, and there's something that can be really effective for our patients. And I don't want to do anybody a disservice by not providing them this technique that I really think could help. And, you know, getting around this law and getting this endorsement is going to be huge for me in my practice. And eventually, you know, my goal is eventually to have my own shop. And I want this to be a big part of it. And, you know, I think these techniques can also bring light to what we can do as PTs. You know, majority of people I talk to all they think I do is prescribe exercises, and it's absolutely the furthest thing from the truth, you know. So yeah, I really, you know, think these techniques are safe, and depends on who's wielding it. We need to grade our forces, practice daily, and just like, you know, chiropractors and any other practitioner, we should be able to do these techniques. So I think that's kind of my stance on it. And Mike, you have any other points to add on that?
Well, to wrap us up, we're going to refer back to the title of our article for today. It's The Safety of Thrust Joint Manipulation in the Thoracic Spine, a systematic review by Emilio Puentador. And what we can pretty much all agree on here is that this article is suggestive that, yes, while there are adverse events that occur, and these are probably underreported because, again, what Darren said, he was just not reporting it. A week later, they don't want to come back. I think we can all agree that these are safe techniques, but it all depends on who's carrying it out. Do they have the right clinical reasoning and decision making to think about who is the proper candidate for this technique? Do I have the right training for it? And can I carry it out confidently and grade my forces in the right amount of quote unquote dosage, for lack of better terms? So with that being said, I want to thank all of you guys for tuning in today and listening to this episode. I had a great time discussing this. It was a very hot topic, and I think we will continue to hit this topic on the head to try to push the profession forward. I want to thank Dr. Tristan Barrera and Dr. Darren Fernandez for tuning in and again sitting through this article discussion. But I want to give a special shout out and thank you to Dr. CJ Vaughn for tuning in with us.
Thank you, guys. Thanks for having me on. You know, Studio Studs coming together once again here. Shout out to Xavier Peters, Dr. Peters out there in Brooklyn, another one of our Studio Studs fellows. And I look forward to, you know, pursuing further knowledge with you guys and hopefully coming back on and discussing more topics so we can, you know, further our education and become, you know, better practitioners. And appreciate you guys. Thank you.
Of course. So, guys, that concludes today's episode. Stay tuned for more episodes coming out soon.